So this whole concept of APM development or alternative payment models and why do we need one, and that probably, if I could get that message across, that may be one of the best things I can do in this presentation. Remember that the Affordable Care Act came after MACRA was already approved by Congress with overwhelming bipartisan support. And the reason why we have MACRA is because we were for 20-some plus years kicking the can down the road with the sustained growth rate, or the SGR, which was a proverbial sword of Damocles over all of us, that we were going to have marked reductions in our Medicare reimbursement. So finally, when they got, they did the MACRA, which got rid of the SGR, but what we brought in instead with MACRA is this whole new way of getting reimbursement methodologies and metrics, i.e. the MIPS, Merit Incentivized Based System, and APMs. So I'm going to talk a little bit more about that. So which of the following is true? Over 60% of urologists are exempt from MIPS reporting. MIPS penalties apply to Part B drug revenue. Approximately 20% of urologists nationwide participate now in APMs, and physician groups of 10 or more may report MIPS as their tax ID number rather than an individual NPI. So, okay, so actually, most of you got this wrong, and I'll keep I'll give you the information as we move along here. So, background: why do urologists need an APM? Bottom line, why we need an APM is it comes down to reimbursement, pure and simple, and hopefully I'll be able to explain that to you. So MACRA provides these 4 different statuses, so to speak, for you and your clinic or your partnership or your employment. You could be in the MIPS only, where these are practices are only participating in MIPS and have no APM model. MIPS with an APM, or sort of a hybrid, and I'll show you why that becomes, these are all relevant as it relates to your reimbursement or lack thereof. There's a partial qualifier where the practice is achieving partial qualifying thresholds, and you have some upward adjustments of the MIPS as well as in your APM model, and then you're in a qualified for an APM bonus, and these are practices that are participating in a true eligible APM, and they receive this 5% bonus as well as the APM model payments. So getting back, remember there's these 4 new metrics that came in with the MIPS that replaced other things such as PQRS and meaningful use and value-based modifiers. And so once again, there's this whole word salad of acronyms that you have to have a team to help you adjust to, and you're seeing it now a lot largely in your EHRs. So CMS estimates that little over 12,000 physicians, 1.1% in the entire United States, will qualify for an APM in 2017. Mind you, the MACRA legislation came out several years ago, and we're not making a lot of rapid progress here. Now, why is that important? Well, if you look down at this table, what you're seeing is that in order to get the requirements for this APM incentive, which is where all the bonus pool of money is, and going from 2017 and into 2018 and ultimately to 2022, where you're going to receive this and be eligible to receive this is if you qualify for an APM. And right now, only 2 urology practices that I'm aware of in the entire United States are part of an APM. So CMS estimates that 88 urologists of the roughly 10,000 will qualify as an APM in 2017. So, bing, 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 light goes on. Government's telling you with this chart, this is where the bonus pool of money is, and yet we're being clearly excluded from it. If you don't care about it, then then none of this would be germane to you. But if you're running a clinic, if you're running an academic department, if you're running a practice, if you're any one of these things, and you have a lot of employees, these become very important. So when fully implemented, the resource use to be 30% of your MIPS score eventually. Right now, the resource use is the costs that you're generating. Now, this is all basically comes up as you don't report it. This comes through CMS claims data, and CMS will use this to attribute patients to physicians through your tax ID number if you have greater than 25, not 10, greater than 25 eligible physicians in your group. This helps you get to APM reporting. It's a two-step attribution process. Now, this attribution process can sometimes, when I've heard people talk about it, you sort of get a deer in the headlights view on it, is who is primarily doing the majority of the patient care. So is there a primary care provider who has the plurality of the E&M codes designated as referable to the primary care? You'd be amazed how many patients you might, if you were to look at your own data, only come to see you as the urologist. And thus you can get attributable to their total cost of care if you've seen somebody for 1 or 2 or 3 urinary tract infections during the year or asymptomatic microhematuria and you're part of this, and lo and behold, that same patient who may have other kind of drug-seeking behavior or weird comorbidities ends up hospitalized and getting all these complications. This person then becomes attributable to you and your group if they've not seen anyone else. So that's really the final button, the bullet at the bottom one. How do I change it? Oh, okay, there you go. MIPS is not in the practice control. The physician to whom the patient is attributed is assigned all the costs from that patient. So this now starts to speak to this concept of bidirectional risk or two-sided risk adjustment, which is a big theme of moving the risk away from the payer to the provider, i.e. us. So all costs for a patient, inpatient, outpatient, ancillary, Part B drugs can be attributed regardless of who provided the service. So if you are the considered the plurality of service, and then they go in and they have a dissecting aneurysm, and you're the attributable provider, that all goes back to your bottom line and can really affect the cost calculation on a normative curve. Next, please. So the MIPS performance categories, the resource use. This is the part that they're looking through in claims data, and it can also be 98% of it is attributed to E&M visits. And this is from Deepak's own practice, and he looked at his data and IMP, Integrated Medical Physicians, and they saw patients in only about 20% of their actual hospitalizations. So the median number of E&M visits to generate attribution to their practice, next please, is the number 2 should pop up. And he actually shared with me in his own personal review, and he's primarily doing largely administrative work, but he still sees patients. And he had this woman who came in and who he'd seen for a few urinary tract infections, relatively uncomplicated. Turns out she ended up getting very sick, unrelated to anything with the urinary tract. And his score, based upon that, in his review, put him in his group of over 80 physicians as one of the highest resource uses in his group, despite the fact that he has one of the lowest patient volumes. So, second question, which of the following is true? Qualified participants in an APMs have maximum revenue upside under MACRA. The MIPS bonuses are constrained by MIPS penalties. MIPS comparison pools are specialty-based. Medicare regulations prevent physicians from losing money on Part B antineoplastic drugs. Yeah, well, most folks got it right, so that's good, okay? Number 2, next. So MIPS exemptions are not equal across the specialties. This is actually was revised by Deepak prior to coming here. So CMS has increased what's called the low volume threshold exclusion, and as a result, 63% of all Medicare clinicians will be exempt from MIPS in 2018. But look how high up we are as a specialty as being eligible for the MIPS in comparison to some of the other specialties. So there's this sort of odd conundrum that we really need to follow up and be cognizant of it. Now, one of the things that just came out in all of this was a change in the rule of and taking a little bit of the teeth out of the penalty and the bonus for this year, so that it's really not going to be as draconian as it appeared to be. But it's some of the updates and the adjustments. So if you're in this scoring threshold and you get a score for those 4 different metrics within the MIPS, if you're less than this 25% threshold versus 25% to the above, which is vastly increased, they've taken a lot of the teeth out of this. And so there's a small percentage of folks who can be be above the threshold for the composite score, but even the pool of money, which I think is about $500 million, if I'm not mistaken, has to be divided amongst all participating physicians. So it's normative, it's not criteria-based scoring, it's all physicians, not just urology, and there's a huge exempting of many physicians who pose challenges to so many of us. So we're being in a big pool with primary care physicians and everybody else. So this has to do with drugs, and if you're into systemic therapies and if you're giving a lot of oncologic care, just pay attention, as you can see to the far right, how if you're in the penalty situation and you're giving Part B drugs and ASP percent as opposed to and you're in the bonus pool, so if you're getting 4.4% because of the sequestration, it's not really a true 6%, you could get, if you're in the bonus pool, you can get an additional 11% on say a $100,000 treatment versus getting a negative 3.3%. So in a large practice, whether you're a medical oncologist or urologist, and as more and more drug therapies become intermixed in all of our GU oncology, this becomes extremely relevant. So by 2022, which is not that far off, low performers versus high performers, there's a huge swing in just Part B drugs alone. Important for our industry colleagues to recognize. Now, this just tells you, if you look at the top kind of light Carolina blue color, I can't believe I just said that as a dookie, but MIPS with APM, that's your maximum gain. That's where you're going to do the best in terms of the economic status, and you can see all those different kind of categories that I mentioned earlier. So why am I telling you about this? I'm telling you about this because we at LUGPA put forward an APM this year. There are no APM vehicles specific to urology practices right now in the entire country, and less than 1% of urologists qualify for an APM. The MIPS exemptions unequally distributed. Only 2.1% of urologists are exempted. Only 2.1. The remaining physicians, we compete against all the other top performers. Succeeding in MIPS is ultimately out of your practice control. Your resources are based on claims data. You'll get penalties potentially under Part B medications if you're not monitoring your metrics. And it's the MIPS APM category that has to be obtained. And right now we can't obtain it because it's not within accessible reach. So we have put forward an APM at the LUGPA level. So which of the following is true regarding APMs? It's the only mechanism to approve an APM is through PTAC, the Physician Focused Payment Model Technical Advisory Committee. CMS has issued clear guidance on requirements for APMs. Integration of care is a high priority focus of APMs. And 4, the CMMI has implementation authority over APMs. All right, so the correct answer is 4, and I'll go through all the data for this in a second, or the reasoning for this. So not every disease and condition is suited for an APM. A big part of the APM for CMMI is they want to see savings. It's all about savings. Remember, we got rid of the SGR. It's about savings, and it's about putting the provider at bidirectional risk, meaning you could make more money if you do things really well. Value is outcomes divided by cost. Or you can get your clock cleaned if you don't do it well. You actually can end up losing more money than you had bargained for. So the characteristics of for an APM consideration. Treatment costs are meaningful for the payers, and in this specific case, this is CMMI. Numerous treatment options and or an evolving clinical paradigm. We chose to look at the notion of newly diagnosed patients receiving active surveillance versus active intervention, and treatment variability in clinical practice, which there clearly is lots of variability with intra-practice, inter-practice, inter-region. Net cost savings of variability narrowed and with treatment sequencing be changed, and be able to define quality metrics and outcomes to ensure that their cost savings do not come at the expense of patient care. In other words, let's just stop ordering tests and therapeutics, save a bunch of money, and it can't work that way. You have to demonstrate quality outcomes. So the scope, how many practices or numbers of physicians or other eligible professionals have expressed interest and willingness to participate in the model if it is approved? You have to get support from your specialty, and it has to have applicability to non-Medicare payers. How many physicians or other EPs, eligible professionals and patients, could participate in the model if it was expanded to scale? So when we proposed ours, and we're still in the process, it would be opened and complete public exposure to the entire universe of your specialty. The portion of national episode that is reasonable to include in savings estimates. Again, this is something that is very carefully reviewed, and so these are big budgetary assessments and a reasonable basis for increase in target utilization based on clinical analytics. And a lot of that clinical analytics requires population health experts, which of course requires resources and spend. Quality metrics, how many? CMS does not provide any guidance, zero guidance on what the metrics would be. Use existing or develop new ones? Well, there really aren't any, so we are now creating these. This is a complete work in progress by multiple different specialties, although right now there's, I believe, only about 5 or 6 in the entire world of medicine in the United States that have any APM approval. And this is now going several years into this process. So how do you tie quality performance targets and performance-based payment and repayment? Well, it's a very big moving target, and it's regional versus practice. There can be low volume thresholds for receiving 100% of your regional pricing, and a lot of this will vary, again, depending upon your region. As we talk frequently about the heterogeneity of prostate cancer, there's amazing heterogeneity in how we practice in different parts of the country and sometimes even within counties. And whether to allow the practices to voluntarily accept 100% of regional pricing, this is an ongoing work in progress, and it's complicated. And so there's low volume thresholds for applying these floors as well as upper bonuses. So you have stop-loss programming potentially. Very interesting. If and when any of these things get approved for us, it brings into a whole notion for those of you who think about insurance or reinsurance methodologies to guard against stop-loss. So how do you define an episode? Well, there's a methodology to attribute the episodes to practice. I alluded to that earlier. There's a relationship of the APM to other APMs. The classic one right now is the oncology care model, where there's about a $165 per member or per patient per month fee to basically do all the encompassing care for the oncology care process. And that's, a lot is being learned about that, and we actually tried to model our APM off of that with a marked reduction in that fee component. So in the monitoring and the auditing, there has to be monitoring for increased prevalence of prostate biopsy, particularly talking about our active surveillance, active intervention, potential APM. And there need to be monitor incentives to either start patients on active surveillance versus not, monitor incentives to keep patients on surveillance even though they should appropriately start an active treatment. And as you could imagine, and we talked earlier today about surveillance and screening appropriately and intervening or not, thinking about how you now integrate that into an economic business healthcare model has taken on its challenges. This is what we're trying to address. So how the model would lead to greater integration and care coordination among practitioners and across settings. A completely tabula rasa, blank slate moving target. To what extent would the proposed model result in changes in workforce requirements compared to more traditional arrangements? Well, in order to do things well, oftentimes, as we all know, it can no longer just fall on the shoulders of the clinician. There has to be a coordinated care team, and that includes advanced practice providers, that includes medical assistants, that includes all of the people who have to input in your EHR and take the time and make sure all these things are being documented accordingly. Next, please. So HIT, the timing and frequency of data transmissions from CMS to participating practices is a methodological requirement. Will any of these HIT innovations be used to support improved outcomes, improve the consumer experience, enhance the efficiency of the care delivery process? These are the questions that you get asked when we've presented now to CMMI as well as to PTAC. Include aspects other than requiring the use of the CEHRT, which is necessary for classification as an advanced APM, and of course ECQM as well. So the patient choice. How will the model, I'm hoping that most of you are able to follow a lot of this sort of arcane acronym soup salad discussion of government health policy, but I think 99.9% of our patients are really clueless to all of this, other than they see us come in now with laptops and or scribes. How will the model impact decision-making ability of beneficiaries, and how will the model impact the right of beneficiaries to choose their own provider and site of service? Well, this is, you talk to most of your patients and they have no idea that this is going on. But this is what's some of the discussions that's happening now at MedPAC and at CMMI. Next, please. So question 4, which of the following is true? Urologists have amongst the highest obligations for MIPS reporting of any specialty. APM development is a time and resource intensive process. Resource use does not require provider reporting, or all of the above. Okay, super. Yep, it's all of the above, unfortunately. Next, we were at our APM thing for almost 2 years now. Could never have done it without, significant industry support, as well as a backbone of a project manager in the form of Integra Connect. This is an enormous process, and it continues and goes on. We actually were very fortunate to get strong support from the AUA and the AACU. So the development of an APM is difficult, it's time-consuming, and it's very resource-intensive. Once submitted, the approval process is lengthy, it's ongoing. We don't have a urology-specific APM in this country, and it should be clear to you why it is important for the economics that are in front of us and all other aspects of medicine. If recommended by PTAC, there's no guarantee that CMS will adopt their recommendation, whether it was positive or negative, and there are no recommended proposals by PTAC that have been implemented to date. So why do we do it or any of us, and why at LUGPA are we doing this? Next, please. Well, you can, just add some instant apathy, as you see here. I think it's a funny cartoon from Deepak. Just add water, whatever you want. I really don't care. Or, as I said earlier, if you're not at the table, you're on the menu. And that's one of the things that were really important to many of us, and frankly, to the entire specialty. So what now? Don't panic and carry a towel. Next. Einstein failure is a success in progress. I ran over, so I apologize. Thank you.